So I think the only reason that I'm here is because probably I use a little bit of Indian-made valves when I come here, and so we probably I deployed probably about 5 of the first 30 cases that led to the approval by DCGS in India. So the landmark trial is a very important trial, and I have no disclosures for this trial. And early outcome of a randomized non-inferiority trial comparing TAVI devices. This was presented on May 15th at the EuroPCR by Patrick Soares, and the PIs are Andreas Bambach as well. So why this study? So as you asked, Pradeep, what is the difference? Why do these Indian valves come into places? Actually, there is a place for all the valves in India, depending upon the affordability. So you can get, Maybach, Edward Sapien to actually the Tata Neo, maybe of a Hydra, right? So there's a big range. What do you want? How much the patients can afford? So, but that said, the effective orifice area, the mean gradients have been really proven to be equal compared to whether the deluxe type of valves that we have as well. So the major evidence of TAVI has been mainly obtained with only Sapien and Evolute transcatheter heart valves, positioning these two valves as we use in the United States as the contemporary standards. The Myval series are not so novel anymore because it has been in use for several years. They're balloon expandable valves whose favorable outcomes have been shown in observational studies. So this is a landmark trial, is the first head-to-head randomized controlled trial comparing the safety and efficacy of Myval transcatheter heart valve series with the contemporary transcatheter heart valve series, which is Sapien and Evolute. So 768 patients, 31 sites and 16 countries, mostly in Europe, Brazil and New Zealand. And a long time ago we did discuss this, and even to probably Sushil and we all spent some time trying to ask them to come to the United States. It's going to cost actually the company more than $1.2 billion at that time, and so I'm not sure whether that will ever happen. So this is a steering committee. As you can see, all the leaders from Europe have been here, and Patrick Soares as the main PI. So how was the study executed? It is a prospective randomized controlled trial, multi-center open label, non-inferiority trial, and a patient with severe native aortic stenosis requiring transcatheter aortic valve implantation as per 2021 guidelines of ESC. And so 768 patients based on the sample size that we will go through. 1:1 randomization of Myval versus the contemporary, which could be Sapien or Evolute, and the index procedure, and the primary endpoint of composite endpoint as per WAC3 definition at 30 days, non-inferiority of safety and efficacy, and follow-up up to 10 years. So the hypothesis is that this Indian-made Myval series is non-inferior to the contemporary FDA-approved valves, and assumed event rate was 26% for each group, and non-inferiority margin was set at 10.44. That is 40% of the event rates, and with alpha of one-sided alpha of 5%, and with the power of 93%, the sample size came as 768 subjects. So the eligibility by a pre-screening committee, and however the final decision was based on the local heart team assessment and the primary composite safety and efficacy endpoints at 30 days are all-cause mortality, stroke, bleeding, WAC type 3 and 4, acute kidney injuries, stage 2, 3 and 4, major vascular complications, and moderate to severe prosthetic aortic valve regurgitation, and conduction system disturbances resulting in new permanent pacemaker implantation, as we always know. The secondary endpoints are individual components of the primary endpoint itself, and the technical success and the device success, and early safety endpoints at 30 days as defined in WAC3, and functional improvement in New York Heart Association class, 6-minute walk test, and question of life questionnaire. So the baseline characteristics as actually on par with the US studies, because it is conducted in the Western world. Most of these patients are 80 years of age, and unlike the ones that we use in India, might be more about 70 years of age. And here the distribution of male to female, actually this is much better than the United States as well. There's a 50% men and women, and BMI is 28 kilos, which is much lower than probably America. And the syncope is not, all these New York Heart Association class 3 and 4 is seen in more than half of the patients. And it's still a low risk trial. 76% of them are STS score of less than 4 in these patients in this study. And so all the other baseline characteristics are similar. There's no difference actually. I mean, this was not statistically significant. Prior CVA or TIA in the last 6 months was actually higher in the Myval series at 1% as compared to the contemporary series. The mean gradients and aortic valve mean areas and EF, everything matches very similar in both of them. And the aortic annular area mean of 471, and bicuspids were only about 6%, and a small annulus is seen in about 1/3 of these patients in both the arms. So the advantage of this Indian-made valve is that there are, obviously there are 7 different sizes as compared to only 4 sizes in the FDA-approved valves. And so that's probably one of the things, that there are intermediate sizes, that is 21.5, 24.5 and 27.5. And as Shabir has shown, there are some ongoing Excel nested registry as a 32 valve that was shown, used by Dr. Rath and his team. And so that I think those are the ones that are in the registry. But in the clinical trials, 7 different types of Myval sizes against 4 sizes of Evolute or 4 sizes of Sapien. The newer generation, which is the octa-core or ultra or FX and the Pro Plus, were not used that much, and predominantly these were the original Myval compared to the Sapien 3 and Evolute R. So that may be some criticism that people might say that hey, we did not compare with the latest generation. But again, the latest generation of Myval also was not used except octa-core was only in 32% of the patients. So what is the advantage of Myval, as actually is presented here as well, that intermediate sizes were used, and as you see in Sapien and Evolute, majority of them are actually in the 29 Evolute or 26 Sapien, about 20% or more than 20%. Whereas in Myval, actually they are equally distributed about the intermediate sizes. 24.5 was used in about 25% of the patients roughly. So you can see that intermediate sizes were used more often in the Myval. 48% of patients in the Myval series were implanted with the intermediate sizes. Probably there is what is lacking in our FDA approved valves is that there is a jump of 3 or 4 or 5 millimeters, and we say that based on the bench testing you can add 1 cc to 3 cc or 5 cc. I think this is all actually on bench testing, which may not be truly reflected in patients' profile. So whereas the intermediate sizes gives us the ability that you can only overlap of about 1.5 millimeters, and also so that is the greatest advantage of having intermediate sizes in Myval. So what are the essential results? Actually, in the probability plot of non-inferiority margin being at 10.4%, and the Myval has shown that the primary endpoint was achieved in 24.7% versus in the contemporary arm of 27%. So it actually met the non-inferiority endpoint with a p-value of 0.001. And so there is no doubt that very clearly this trial showed that the primary endpoint is results are in favor of the for Myval series by meeting the non-inferiority endpoint. So in how about the superiority wise? I think it's still, with the confidence interval of being quite long, I think we can't say that this is superior, but probably there is a trend to be more in favor of Myval and in the primary endpoint, which is superiority. The individual endpoints that did not make much of a difference, except a slight bleeding was observed in maybe type 3 and 4 bleeding in Myval series of 1.6%, 2.9%, and compared to contemporary of 1.3%. But there was no difference in vascular complications. So this is non-vascular bleeding rates, which probably we have to keep an eye on that wise. So, and acute kidney injury as well, slightly higher, that actually we were talking about in people with maybe renal disease or not using too much contrast was the reason that in probably in Evolute probably they use less amount of contrast as compared to in Myval series. So, what about the effective orifice area, compared to Myval series in the green, and you can see that in the red is Sapien, that is slightly lower effective orifice area, and that is probably again related to the intermediate sizes that were available with the Myval series. And whereas the Evolute series actually is slightly matching with Myval. So, all three, if you look at it, that there is a higher effective orifice area with the Myval series as compared to the other contemporary valves. And the hemodynamic performance of a Myval and contemporary heart valve series is actually shows that actually at the end of 30 days and the mean gradient is still in single digits similar to both the arms, and so I think this is a great achievement for this valve. And so, how about based on pre-procedural CT scan and effective orifice area, obviously it's much tighter, and you can see that Myval actually gives us better effective orifice area compared to the contemporary valves based on the pre-procedural CT scan annular area. So, the results are available on Lancet on May 21st, and please if you want to read more. And so, landmark comparison of early outcomes of new generation Myval transcatheter heart valve series against the contemporary valves of Sapien and Evolute in real world individuals with severe symptomatic native aortic stenosis. So, why is this trial important? This trial is actually important because always there was a criticism that there is no randomized controlled trial against Indian manufactured Myval, and obviously there has been, as some of you probably know, there has been real criticism against this valve compared to other FDA approved valves, as we don't have any large randomized controlled trial. So, this is one of the first head-to-head comparison against contemporary valves, and the landmark trial has expanded the indications of TAVI to those with complex anatomy such as small annuli and bicuspid valves. And the trial establishes the non-inferiority of Myval series compared to other FDA approved series, except for the slightly increased risk of bleeding and acute kidney injury, which we keep an eye on it, but all the other endpoints are similar. And when they even those endpoints of bleeding and AKI were not statistically significant. When the effective orifice area of conventional THV sizes are compared with the intermediate sizes, we achieved larger EOA in these patients. So, I think the availability of the intermediate sizes that actually will accommodate the other 48% of the patients who probably would have been either undersized or oversized, and by using -2 cc or a +3 cc similar, those I think measurements may not be clearly accurate. And continued follow-up of 10 years will unravel whether the documented effective orifice area will have a beneficial impact on the long-term patient prognosis and valve durability, which we have to wait and see. I think lastly, this is actually again cobalt chromium, the newer generation of octacore is anti-calcium treated bovine pericardial valves with open cells on the top and closed cells in the bottom. So, it gives a really good tensile strength and radial strength, and looks very similar to Edward Sapien, but is obviously the intermediate sizes does help, and we are cost effective in the Indian population. With that, I'll stop here and I'll be happy to take any questions.